Morning, everybody. Thank you, Elisa, and good morning to all of our online friends who couldn't be with us in person. As Elisa said, this is our fourth annual Method Summit. We started doing them first one was in 2020, and really the purpose of the Method Summits were about convening disparate actors in this space for conversation about how are we going to improve both the process and the practice of health technology assessment. So in the spirit of that, we have tackled some very complex themes over the last 4 years, including how we value innovation, which was last fall, including how we bring patients more centrally into the process of health technology assessment, and how we explore new and evolving methods in this space. So today is no less ambitious in its focus. We are delighted to be exploring some of the insights that we have built over the last year, working with a variety of stakeholders and over 40 hours of dialogue with patients, with researchers, with clinicians, with people who are very much more expert in the area of health equity than we are even. And so the insights report, which you may have seen released last week and which we will make available to all of you, explores the fact that we have actions we can take in all of these domains. And the beauty is that there is something for everyone in this report. And we hope through these panel discussions and our dialogues today to unpack some of those ideas and to challenge all of ourselves, no matter where you sit in this ecosystem, to take on the responsibility and the challenge of doing something to improve how we bring patients, and particularly patients who are marginalized, who are not well represented in the data, and who have disproportionate impact when we make decisions without full view of diversity and of an equity lens. So that's really our purpose today. As many of you know, I've been with the organization for 5 years, over 5 years. And one of the things that I like to say about the organization is that it's in our DNA to tackle complexity. If it's not complicated, we're not interested. So I think that's very much the case in this topic area, which we started to explore in 2020 during the pandemic by working with ISPOR to host a webinar series about how was COVID really changing our perspective about this process of health technology assessment. And one of the issues that came up was health equity. We talked about equity even beyond the US borders, thinking about availability of vaccines, about how clinical trials were conducted and things like that. But it got our whole team interested in unpacking, well, what's the intersection of equity to health technology assessment? And that led us to a webinar series in 2021, in which we laid out the framing, and that led us to start a 2-year health equity initiative. So today is a way station. It is not the end of this endeavor. It's kind of a point in time, and we're through our panels and our discussions, we're going to be sharing with you where we've come on this journey and laying out, I think, a pretty ambitious call to action for all of us to get up off our seats and do something different. So that is our theme today. As I said, you'll hear throughout the day, I'll be on a panel shortly, so I'll be able to dig into this a little bit more granularly, but we are focusing on action and collaboration as in everything that we do. Before I hand off to our CEO, Jason Spangler, I do want to call attention to one thing. On your table, you may see little tents that have QR codes, and there's no label on it, so you're thinking, what is that about? The QR code is, if you scan it, it will take you to a variety of resources that have been shared with us, both by our speakers. It has the report that we just put out and other resources that are available to you. So please do take advantage. If you're online, we will be posting links to those resources as well as some resources that were shared with us just a tiny bit after we needed to have everything organized behind a QR code. So we will make sure that we post those things as links. And for all of you in the room, we will follow up with a post conference email that has those resources available to you. So with that, I'm going to turn things over to our CEO, Jason Spangler. Thank you.
Thank you, Jen. I also want to give my welcome to everybody here in the room and the many people that are online. Thank you for joining us today. This is a very exciting day, 2 days actually for us. A lot of work went into this, and it's just great to see this come to fruition. I also want to thank our board. I actually just saw one of our board members walk in, which is awesome. And I know there are some other representatives here from folks from our board. So thanks for our IVI board for supporting us as well. And you might have seen this earlier, but I also want to thank, we have some sponsors for this as well. So Pharma itself and Alexion and Janssen, thank you for support. And also some of this, particularly the work tomorrow, is also supported by a PCORI grant, which we have a great partnership with PCORI, and we just love working with them, and we're appreciative of the support that they provide as well. I'm not going to go over, you have the agenda in front of you. I just want to say a couple things about it. And Jen highlighted some of this already. There's been a ton of work, and she mentioned the hours, et cetera, but a lot of work has gone on over the last year, which you're going to hear about starting today. And I want to emphasize that starting today, because this is just the first, and actually last week was the first, if you saw the report, of many things that are going to be coming out from IVI about this. And I want to emphasize the start, because this is a complicated, as Jen mentioned, a complicated issue. There's a lot of work that has to be done. It has to be done way upstream. And we actually feel, from what we've heard from all the people we've talked to, that fundamental change has to happen within HTA. And it's not something where you can just put out one paper or one report and think that's the end of it. It's something that has to continue and has to fundamentally change how we do things. So that's why we think that this is just the beginning, and we're going to continue to work on this important issue. Tomorrow is going to be exciting as well, with when we look at economic impacts, and you will, I think, if you haven't already, you will easily see the relationship between day 1 and day 2. There's obviously a lot of overlap between them and a lot of things that are related to both. And I think we can address some of those similarly as well. So just stay tuned for tomorrow, because that'll be interesting as well. I think the last thing I want to mention is that after this is done, I want to make sure that you guys are still engaged with us. We don't want this just to be, again, as I said, not just a one-time thing, but even this event to be a one-time thing. We love working with all of you. We love our members and our partners and our collaborators. And so if you have continued interest in this, what you hear today, and anything else around IVI, just want to say, talk to us. We love, collaboration, partnership is what our organization is about. And I think most of you know about our organization, but if not, talk to any one of us. I'd love to tell you more about what we're doing. This is a very exciting time. And I'm not just saying this because I started here about 7 or 8 months ago. It was exciting even before I started, but it's very exciting. A lot of growth is happening in the organization, a lot of work that we're doing around projects and initiatives, and we're very excited. The environment is very exciting. I know you all know what's happening in this environment, and so we want to be part of that as well. So please join us and partner with us. So I'm going to call up our first keynote, and that is Dr. Dora Hughes. So Dora, if you want to come up, we will start, and I'll grab a mic. Yeah. Can you hear us? All right. So we're going to do a little fireside chat here. I always find these funny because there's rarely ever a fire. And I think I need to move over a little bit. So we might be a little close. But I love these kind of discussions because I think having a dialogue and a Q&A is an important way to learn a lot of information versus just someone talking to you. So I think this will be really exciting. I'm going to introduce Dr. Hughes in a second, and then we'll start into the questions. We will have an opportunity for Q&A, and for those who are in the room, if you do have a question, for those online as well, please introduce yourself so we know who you are, and then we can ask the question. So I think many of you know Dr. Hughes. So Dr. Hughes is the Chief Medical Officer of the CMS Innovation Center, or CMMI. She has a long history within HHS, which we'll talk about, but currently in her role, she leads their efforts on a lot of the stuff we're going to be talking about today, including health equity, clinical leadership, the different models they're doing. And she's also the primary liaison with the main stakeholders that they work with, as well as CMMI's clinical community. Prior to that, she had an associate research position at the Milken Institute School of Public Health at GW here in DC, and did a lot of the similar work that we're going to be talking about today around social determinants, health equity, community health, healthcare quality. Before that, she was a senior policy advisor at Sidley Austin, where she advised them on regulatory and legislative matters with the life science industry. And then, as I mentioned, she was in HHS even before, as she served as a counselor of science and public health for Secretary Sebelius, and helped, I think probably the most important thing you did there is help the implementation of the Affordable Care Act. And so you can talk about that as well. And then she also started her career at the Commonwealth Fund, and also relevant to her government work, she was the deputy director of the Senate Help Committee under then Senator Barack Obama. So a lot of interactions with the former president. So thank you for being here, Dr. Hughes. So
Thank you.
I'm going to start with kind of what you're doing now, and health equity is an important part of the priorities of CMS, as well as the Innovation Center that you work at. What do you feel like in the past few years the Innovation Center has been doing differently around health equity as it's been a priority?
Yes, I want to start by thanking all of you for inviting me to join you here today. And certainly it was an unexpected pleasure to run into old colleagues and friends from my prior time at HHS. I would say for when we think about what are we trying to do differently at the Innovation Center, I really would take a step back and just tell you a little bit for those that are less familiar with the Innovation Center. We were created as part of the Affordable Care Act in 2010. And we were charged specifically to test models of care that either improve quality of care or reduce the cost of care. Ideally both, but at least one or the other prong have to be addressed. And through that, we have supported about 50 models that have tested all different types of initiatives, whether that's tackling certain disease conditions such as cancer or diabetes, different provider types, specialists, primary care. We have focused in different geographies relevant to the conversation of equity, whether that's urban environments, especially certainly rural. I've also looked across all of the different types of insurance lines, so traditional Medicare, Part D plans, but also Medicaid. And I often tease my colleagues at Marketplace that we're coming after you next. I'm not sure if that's going to happen. But in any case, and so we have, at one point we did a 2-year study to try to see what is our reach. And we found that in a 2-year period, we had touched over 28 million beneficiaries. Over 500,000 providers or provider types in some ways have been touched by our models. We were across all 50 states, number of territories, DC. So we've had a fairly expansive reach. That said, and right at the end of our 10-year anniversary period, which corresponded with the change in administration and direction there, it made sense to take a step back and think about what have we done, what have we accomplished, and what do we want to do in the next 10 years? What should our 2030 goals be? And one of our many lessons learned was that in the first 10 years, we had not really focused on equity. We had not considered equity in our recruitment strategies. When we looked across the patients being served in our models, they were fairly homogeneous. They tended to be higher income. They tended to be white. We didn't have enough safety net providers. We weren't in enough underserved areas. And also evaluation, which I know is something that IVI is focused on. Because we were not focused on equity, we did not ask the questions up front that would allow us to collect the data that we need so that at the end of a 5-year model or demonstration, that we would be able to assess the impact of our model on health equity. So with all of these kind of lessons learned, taking a look back, we released our 2030 strategy a little over a year and a half ago, and our vision statement is a health system that achieves equitable outcomes through high quality, affordable, person-centered care. And I would say right there from the start, from our leadership, that they wanted equity to be right up front in our vision statement. And I certainly note that in your report, you mentioned that it was important right from the start to be very intentional about the focus on equity, and that's very much aligned with what our approach has been at CMMI. But we also developed 5 strategic objectives that I'll touch on super briefly. The first one is focusing on accountable care. How can we make sure that 100% of our beneficiaries and the vast majority of Medicaid beneficiaries are engaged in relationships where there is accountability for the quality of care and the total cost of care? Our second strategic objective focused specifically on health equity. How can we advance health equity? Our third area is really thinking about how do we support innovation? What is the data, which I know is another area of focus for IVI? What's the data that is needed for us internally as well as for our participants? What are the learning systems? What's the technology? Really thinking about the infrastructure. The fourth area is really thinking about how can we address costs in the system. And we initially looked at that at a high level, like how do you get rid of duplicative services? How do you think about waste? All of that. But we're increasingly focusing more at the individual level, particularly through the IRA or even the executive order that tasked us to look at high drug prices and thinking about what does it mean? How can we drive down the prices for the beneficiaries in terms of cost sharing? And the final area, which is critically important, is partnership. Another area that very much aligns with IVI. So glad that I'm here, so we could have this like IVI love up here. But the partnership, and really as we thought about the first 10 years, we were so fortunate to have an amazing cadre of partners on the provider side, both hospitals, health systems, and we're grateful we continue to have that partnership. But where we really needed to expand our network is really thinking about what about the patients, what about the beneficiary voice, and the groups that represent them, and that certainly with the additional asterisks for those representing underserved populations, the safety net providers, wanting to engage them as well. So I can continue to go on, but
Can we go a little further?
About has your approach to patient engagement or beneficiary engagement changed, because of what you just talked about?
Absolutely. I would say, since I already said that this was the area that we felt we wanted to do better, we wanted to do more. We did internally take a number of steps. We had focus groups in the beginning that I think it kind of hurt our feelings a bit. When we talk about accountable care, we realized that patients are like, we have no idea what you're talking about. And so it really forced us to think, like, what is it specifically that when we talk about accountable care, how can we clarify that we were talking about care coordination, communication, engagement? I mean, so being really plain, and we had to talk directly to patients to do that. We also have had a number of beneficiary listening sessions where, again, we've heard from the range of groups, not in the specific focus groups, but beneficiaries where we could hear, but they could also interact and engage with each other to really understand what are some of their priorities. Another area is really thinking about our quality strategy. How do we include more measures that are important to our beneficiaries? How do we include more PROMs or patient-reported outcome measures? And what is the strategy there? And so trying to think through our models. How can we include PROMs in each model moving forward if it's a relevant model, of course, to touching patients? And so I think, again, just being really intentionally, what are the various steps along the way that we can include beneficiary voice? I would say I would add one more thing. Because we hasn't always been a strength of ours, another key part of the strategy is working with some of our federal colleagues and agencies where historically they have had closer relationships with beneficiaries in communities and particularly with underserved communities. And so as an example for that, we are working more closely with our colleagues in the Health Resources and Services Administration, thinking through how can we better align our efforts. And so if, for example, we have federally qualified health centers participating in our models, we shouldn't have different data requirements that they are reporting to UDS or data systems. And so it is taking quite a bit of effort to think about how do we work more closely, but we are certainly being very genuine. We are also working more closely, having conversations with the Administration for Community Living is another example. They have the area agencies on aging. I mean, they are directly, again, on the ground in the communities. They have the footprint. that in many cases we do not. And so those are some of the examples of how we're trying to do more.
So you talked about a lot of things that you're planning. Is there anything else that you hadn't touched that's kind of on your to-do list that you want to add? 2030?
There's many. Me or?
Was it me? Sorry. Oh, was it? Sorry about that. Let me repeat that. Sorry if you didn't hear, it was a little shaky. So you mentioned a lot of things that you're doing now and that you plan on doing between, for your 2030 goals. Is there anything else on the kind of to-do list that you didn't talk about that you want to mention for you guys?
There's so much on the to-do list, and so we can go in any direction.
Anything related directly, say, around health equity?
Oh, sure.
Yeah.
How much time do we have? No. And so I would say if we talked about, in addition to our 5 strategic objectives, we have started to flesh out what exactly are the areas of focus for our advancing equity strategic objective. And within that objective, we have 4 areas of focus. The first area is when we develop new models, or if we modify models that have at least 3 years left, how do we better embed health equity? And by that, we mean, what are some of the care delivery requirements? What about the care teams? How do we include community health workers, for example, or doulas, those with direct relationships and different types of relationships with patients and lived experience, all of that. Of course, not surprisingly, how do we finance? How do we provide additional funding for our participants that are taking care of a disproportionate number of underserved populations? And for that, we always like to emphasize our models are tests. There's different ways that we are testing, providing financial supports. In some cases, it's through a benchmark adjustment. In some cases, it's infrastructure payments, direct payments up front. And other cases, we certainly, I think for many of us, are exploring risk adjustment. So there's a lot of different ways. And even when you think, even if we, for example, we say we want to do a benchmark adjustment or risk adjustment, then how do we do that? Like, what are when we say for underserved beneficiaries, how are we defining underserved? In some cases, we're looking at duals or those living in areas with high that would score high on the area deprivation index, or so it's even thinking through what are the measures of underservedness that we want to adjust our payment for. How do we define safety net providers? That was crazy. We at one point we met with, it was a whole CMS-wide meeting, and there were so many different definitions that people were entertaining on how do you define a safety net provider. We do not have a uniform definition, and in many cases we should not, because of course we operate so many different programs and policies. But even for that, how do we support those taking care of the underserved? We can talk about it, but when you try to operationalize that, that's when you run into difficulty. So it's fairly exciting. But that's the first area. Yeah. The second area is diversifying our models. I think I mentioned many of our models, they are just very homogeneous. We want to make sure we're serving the full diversity of the beneficiaries that we serve. And so we think as part of that strategy is including more safety net providers as participants in our models. That has required, as I touched on, partnerships with HRSA, require more partnerships with our colleagues in Medicaid, it's more partnerships, discussion with states, so that is a shift. It's hard, very hard work when you're talking about other agencies, multi-payer alignment, but we just think is critical. The third area is, I'm sorry. Don't get nervous. I'm negative. A third area is evaluation.
Water right there if you want to grab it.
No, it's that I made it 3 years without getting COVID. Then I finally got it in January. Not to be nervous. I unfortunately have that lingering cough that so many people have. The third area is protect yourself. The third area is evaluation. It sounds very direct, but as I mentioned, we had not thought about the equity in our design, and so we're trying to be more intentional about that. And the fourth area, which we think is just absolutely critical, is the data. We are requiring our model participants to collect socio-demographic data and, when possible, data on social determinants of health. That too has been, it's easy to say we're going to collect more data, but we're also now working on what are the FHIR-based standards that what are the APIs that are needed? When we get the data, what are the repositories we need on our end? And also being thoughtful. Some of our providers are very sophisticated, of course. they may be able to collect the data extricated from their EHRs. In other cases, we are preparing for those Excel files that we'll have some of the data, and we want to be able to accommodate whatever the mechanism is, because we think data, we need it for our models, we need it for those that are our participants, but we also need it for our control groups. So it's also helping to support just the broader ecosystem of data collection. And the final thing I would say, data, I mean, certainly we have data for racial and ethnic groups, although limited, particularly by gold standard self-report. And certainly we're using proxies in the short term for that. But for some groups, we just fall down flat. And I think as one example are beneficiaries with disabilities. And we know those who qualify for Medicare because they're disabled, but we don't know the nature of the disability. And so how do we have care interventions when we don't know if it's because they're deaf or they're blind or physical, it's intellectual? And so really trying to think about those groups for which data is especially challenging, or for whom we really haven't focused on previously, that's another area that we are diving deep right now. And I think the same could be said, the same absolutely can be said for our beneficiaries defined by sexual orientation, gender identity. Those two, the data is really problematic for us.
Yeah. So that's quite a to-do list. And thank you for sharing all that. You mentioned the priorities, and obviously there's a lot of overlap you mentioned between what IVI is doing and what CMMI is doing. And the initiative, you're a little bit aware of the initiative. We've talked about our initiative and the report that came out last week, and or at least some of the information in that. Are there things in what you know about what we've been doing in this initiative that can help reinforce kind of the work that you're doing? And also, are there things that maybe are challenging to some of the work that you're doing, or challenging you guys in the work that you're doing?
When I read the report, I was relieved in many cases to see that there's no conflict, and that in many cases we were quite aligned. I think the difficulty for us is, and I think touched on the report, is really thinking about how will we measure our success over time? Like in 10 years, how will we know? We have started thinking about that. Last year, we published some measures by which we will be tracking our own performance and reporting and measuring.
Can you talk about what some of those measures might be?
Sure. So if we thought of in terms of and these measures can be found in the strategy report that was released, I think either in October or November of 2022. It's on our website. If we look at the equity measures, they do track some of what I just mentioned. We will be tracking the number of models that collect sociodemographic data, as well as SDOH data when possible. We'll be looking across the number of models that are submitting health equity plans as another example. We're also looking at the number of how we're increasing the number of safety net providers and the safety net institutions. We have baseline data. Where we have baseline data, certainly driving the selection of measures. And then also thinking about on the clinical side, how are we reducing the rate as well as the disparities and the rates of preventable hospital admissions over time. And that relates certainly as we're thinking about episodic care or ACOs. I mean, our investments in primary care, we do expect that we should be over 10 years helping to drive down both the rate and looking both, again, importantly, at the absolute reduction as well as are we helping to close the gap. So those are some of the measures.
And sorry, I didn't mean to take you off the path of what IVI is doing, but is there something else you wanted to, because you were talking about kind of, there was stuff in the report that relates to what CMMI is doing. I think
where we would be looking to IVI and diving deep is really on the operational side. That's where I think at a high level we're completely aligned. But as you talk to your members, as you talk to more of your stakeholders, it would be really helpful to find out more about how people are actually doing it, and particularly with the health technology assessments. I mean that's an area that's a lot of different opinions, and ripe with controversy. It would be really helpful to be able to get guidance in the area.
Got it. You mentioned, I think you just mentioned something about 10 years. So why don't we end with this? What do you think we're going to be talking about around this issue 3 years from now, 5 years from now, 10 years from now?
So I think 3 years from now, because our models are so from the time we announce we're working on a model to the time it's launched is about 18 months, 2 years. That's a long time. In 3 years, I hope that we are looking at a portfolio of models that all have strong equity components. I don't expect our first round of models to be perfect. Again, we're testing. Sometimes we're in a space where like, let's try this proxy measure. It may work, it may turn out to be terrible, but in 3 years, I want to see a number of models with strong equity focus. In 5 years, I want us to have worked out some of the operational details. And for us, so we have statutory hurdles, we have contract hurdles, we have thinking about provider burden. I mean, every office in CMS has provided input, like our Office of Burden Reduction and Health Informatics. I'm not sure until I went to CMS. I'm like, I'm not sure I've heard of this office. But Office of Contracts or Office of General Counsel, I mean, the operational details, again, trying to actually do what we're saying we want to do is huge. And in 5 years, I think we will have a much smoother path for that. And in 10 years, by 10 years, I want to see some actual successes that we can point to that can be both quantified as well as qualified. That's where in 10 years where I expect to be. And I'm actually, people always say I'm always a glass more than half full type person in any way. So I'll confess that. But I truly think that we are going to be successful, just given the energy, the resources, the leadership by our CMS administrator and this administration, and just across the center where we're all moving in the same direction. I always have to give a shout out to my colleagues in the CMS Office of Minority Health, amazing team as well in guiding all of our efforts.
That's great. We have a few more minutes before we get to questions. So I'm going to twist this a little bit. I'm going to ask you, what do you hope we're not talking about in 10 years? That it's not an issue anymore, is there anything that comes to mind where you're like, hopefully we're not discussing this anymore, that we've kind of solved that? Is it a data thing? Is it like, well, we finally have data on stuff that we don't have? I'm just curious or even something like, when it comes to hiring, or you talked about your models that, every one of the models has, engagement that's diverse or something like that. Are those the things? Or I'm just curious.
I'm fairly confident that that equity is a priority, is not going to go away. But I do think the data is really difficult. I feel like that is our key vulnerability. That is the weakness. That is where all of our efforts will fail if we are not able to increase the collection of sociodemographic data from our providers at a level where we can scale, at a level where we can have meaningful evaluations. And this is true across not only for the CMS Innovation Center, it's true for our colleagues in Medicare, true for our colleagues in clinical standards of quality. I mean, it's just a problem just because of how limited it is.
Great. Thank you so much. Well, we're doing well on timing. So thank you, Dr. Hughes, very much. We have about 10 minutes now for questions for folks online or in the audience here. So, and Richard there has a mic. If you just want to raise your hand, he will give you the mic up right here up front. And please, again, announce who you are before you ask the question.
Hi, Dan Touchette, University of Illinois, Chicago. I guess, you're talking about data and collecting data. And part of what we're going to be talking about later today is around trust issues with collecting data. Are you finding that in the collection of this data, that it's difficult to collect some of the needed data because of patient trust issues with who's collecting it, how it's being collected?
To be fair, because we are now just starting to push this out through our newer models, our ACO REACH model, which just launched in January, has sociodemographic data collection requirements. Our enhancing oncology model that will launch in July. Similarly, And so anything we learn at this point truly would be anecdotal. I would note it was flagged to our attention that there was concern mentioned in one, I'm going to make this anonymous, but in one setting and one of our models, the beneficiaries did not care to be asked. I was a bit bemused to see in the place, it was 98% white. And it was about 0.3% of everything else. And so it's hard to know what to do with that. I'm like, well, it's not really our target. I mean, that's, I say we stipulate, we give them all a pass. But importantly, that means we have not heard that concern from more diverse settings and more diverse populations where we are doing work. And so I think that's important. But we'll know more once as we continue to do more. If there are ways that we need to think about how do we collect the data, who are we working with, who's asking the questions, how are we asking the questions. I would note we've also been talking to some of our partners externally, of course. And I think as one example, the Blue Cross Blue Shield Massachusetts has reported on their efforts to collect data. And I think it was over, I don't know, maybe 100,000 or somewhere. I think they had gotten 2 complaints out of that. One was from an Asian American who noted that the categories to select were way too limited. And so, but I think, again, we won't know until 3-5 years if there's ways that we have to change course. And that's for racial and ethnic groups. For other groups, I mean, if we think again about people with disabilities, that's we're even further behind on how to ask if you have a disability, even asking what type of accommodations. I mean, those are whether it's disability or functional impairments. I mean, so we have a lot of work to do. And I think through the Innovation Center, even just by testing some of these approaches and different models will be helpful to the broader field in the long term.
Other questions in the room? Any online? Oh, Simo.
Simon Thomas from Alexion AstraZeneca Rare Diseases. My question is more on how you define equity or inequity, because a lot of times we talk about race, but there could also be other inequities in terms of genetics, types of living, biology, so on and so forth. So is there a prioritization of how CMS thinks about it?
So CMS has a definition of health equity on their website, which I'm not going to get exactly right, but it's basically when all of our beneficiaries have the fair and just opportunity to attain their highest level of health possible, regardless of race and ethnicity, certainly, but also it's in the definition, regardless of geography, regardless of disability, regardless of sexual orientation and gender identity, or any other factor that can impede, that can affect access and quality of care. And so it's a very broad definition. Certainly, we would not prioritize. And I don't know that we could, even if we wanted to. None of these groups are in their own silos. I mean, there is trying to think through the intersectionality between low-income groups in rural areas who may be disabled and maybe Latino. I mean, it's really, we're trying to think very holistically about health equity at a high level for the populations and trying to collect the data to stratify the data the best we can and thinking about how we could tailor care as appropriate. What are the services needed? So it is certainly very challenging, but you have to start somewhere, and that's what we're doing.
Right here.
Hi, Jackie McCoy with Pharma. You talked about the collection of social determinants of health data. And as you were just alluding to, there's so many different social determinants that folks can have, right? And so I'd love to hear you talk about how you kind of prioritize which social determinants you're asking providers to collect.
So that we have to take a step back to 2016, 2017. I always laugh a little bit. We launched our Accountable Health Communities model, which was our first model that really tested the screening, collection, reporting of SDOH data and helping beneficiaries navigate those social needs. I always laugh a little bit because in 2016, it was like revolutionary that CMS would do that. And now it's kind of like, well, at the model of, now that the model terminated last year, it's like, well, of course we would be doing this. But for that model, they did look at the literature and they settled on 5: food, transportation, housing, intimate partner violence, and utilities. We have continued those 5 areas of focus, although mindful that many of our colleagues and internally our models, at least in terms of prioritization, I would say food, housing, and transportation have probably risen in part because of feasibility and operational issues and some of the feedback. I mean, as we've found from our asking about intimate partner violence is an example of how we were asking the question, the settings, who is asking. It's one thing, it's hard enough in some cases to assess housing needs, but when you get to the most personal issues, and particularly if they're there with family caregivers. And so we've had to take a step back and think about how we're collecting some of the data. But for those 3, that's I think those will always remain core to some of our work. And then, of course, that gets at a high level. Then exactly how are we measuring food? The food insecurity, and every organization, our colleagues at CDC, everyone's doing things a little bit differently. So even that, trying to standardize that data continues to be a welcome challenge for us.
Great, thank you. I think we have one more online. One. If you can give it to Melanie, Richard, I think we have one more online question. Oh, or maybe 2. Let's see if we can get them both.
Great, thank you. Dr. Anakula from University of Maryland online asked, thanks for this important discussion. In order to have better data, there sometimes needs to be improved by directional data sharing and trust with populations that are underrepresented. What efforts are CMS engaging in to build community engagement and trust to support CMMI's work?
That's such an important issue. I would say it's a bit of a challenge for us because our relationship, if you think about Medicare, our relationship is with the providers. And so when we have models, contractual arrangements for engagement, all of that has to be with the providers. When we work with Medicaid, it becomes even another step removed because in that case, the relationship is with the states who then have the flexibility to decide what the requirements will be for the beneficiaries in that case. And so for us, it's thinking about still, how do we foster these community engagement? What can we put in our contractual agreements? What can we put in the participation agreements that would incentivize doctors and other providers to engage more directly with community-based organizations, with patient advocacy groups, really thinking about still though, how can we use our funding, our authorities to encourage the development of these types of relationships, even as we on our end are, as I mentioned previously, trying to more directly liaise with our patients, our beneficiaries, and community-based organizations ourselves.
Great, thank you. We have one other question from Tim Lai, who is IVI's Health Equity Fellow. And he asked, how can we make sure or know a model is strong equity focused, defined by CMS? Are there aspects we should focus on more, such as more stakeholder engagement or mainly prioritize social determinants of health data?
So I think if you looked at ACO REACH model, that is a prime example. I think I would encourage you to adopt a life cycle approach for our models. At the very beginning, does the model even have relevance to disparate populations? And I think if you think about our oncology model, for example, in July, they're focusing on cancers for which there are known disparities, colorectal cancer, multiple myeloma, and those thinking about at the very beginning. Then the next step is really thinking about How are we engaging? Who's helping us to develop the models? How recruitment and rulemaking? How are we reaching out to model participants? And as another example, as we got applications in for EOM, we were doing almost real-time analysis to see, are we getting applications from the range of provider types? Are we able to reach safety net providers? And if not, how do we need to pivot to make sure that we are engaging them? I also think in our model design elements, are there pieces in there that would enable safety net providers, for example, if continue on to join our models? For example, some of our models require risk taking. If you're an FQHC, the notion of taking risk when you're serving such an underserved population and your margins are already so slim, the notion of taking on a lot of risk that's a non-starter. You're not going to join our model. So really thinking about what is the financial underpinnings, what are the types of requirements, who must be on the care team. Those types of model design elements, I think, are really important too. And then again, just looking to see, what's the evaluation plan for the models? What are they announcing as part of the model early on, so that at the end of time, again, we'll be able to assess the health equity impact. The final issue I would say for us, and this is the issue for us, is we're also trying to think about sustainability, because even for models that have been successful, in many cases, we're not really seeing the dissemination or the uptake of some of the lessons that we've learned. And so that's another element in our life cycle of models that we're already starting to think about. What's the sustainability plan? How are we going to scale up the lessons and interventions that we find to be successful?
That's great. Thank you. We are right at time, but I want to give you 30 seconds for a call to action. You have various stakeholders here. What can we all do to help support and be helpful to CMMI and the entire agency in these efforts?
I think there's two things I would say that are very helpful. Would be very helpful for us. One is really collecting examples, stories of successful or promising practices or interventions, even if it's early stage. The more that we hear from individuals involved in these efforts, and even early on, we in many cases are changing our approach, making modifications, updating. And the thing is, even with our models now, for those that are launching in the field right now, we're already working on a whole slew of models that are to come, and they're all in various stages of development. And so if we hear that something's working well, or this is an approach, or this is exciting, there are different models in different stages that we could consider embedding, making the changes that might be needed. So I think the more that we hear about what's actually happening on the ground in the field, I mean, that is so incredibly helpful for us. And the other is partnership. We are quite genuine when we say we are trying to develop more and stronger partnerships with a diverse range of stakeholder groups. We hear every day from groups and organizations that want to meet. We have an open door policy. I think to the extent that you have some ideas, suggestions, positive or negative for us, that we would encourage you to reach out and to meet with us directly or virtually directly. That is another request that I would have.
Great. Thank you so much. Thank you so much for joining us today. This was a wonderful session. Please join me in thanking Dr. Hughes. A great start to our summit, and I'm going to turn it back over to Elisa.